This is Advanced Patient Care Theory 2, Unit 2, Part 3, neonatal complaints. So let's talk about some of the things we can anticipate in an unwell neonate. So in that period between newborn and 28 days or so, and maybe slightly beyond that. So an important concept is that signs and symptoms are usually vague and non-specific in the first month of life, and will rely very heavily on the patient's, or not the patient's, but the parents' perception of change in things like the newborn or infant's behavior, their crying pattern or tearing. Yeah, you had a question, MJ? Um, Looks like everyone but Brad has got audio. You guys are hearing me okay, though? Okay. MJ, your mic is unmuted, but is it not working for you?
All right, it's working for me now.
Okay, great. Did you have
All
a
right.
question, or was it just about the mic?
No, it's just about the mic.
Okay. Eating or feeding patterns of the newborn, interaction with the mother, diaper changes, patterns, any increase or decrease in urination and defecation. Sometimes those things are difficult to tell because it's hard to tell sometimes if the diapers are wet, and so on. So the bottom line is, you may attend to a call with a healthy-looking neonate, but if the parent's telling you something's wrong, even if they're feeling terrible about having called you because the baby now suddenly looks better before you arrive, I would take the baby in for assessment. So obviously greater risk if these are premature infants, greater risk of things like hypothermia, and problems, complications with breathing because they have diminished surfactant production and may have trouble breathing, respiratory depression, head injury happens very easily in premature newborns, changes, fluctuations in blood pressure, interventricular hemorrhage as a result of cold stress or gravitational pressure, and fluctuations in fluid osmolality, sepsis at birth, not uncommon, especially if mom had sexually transmitted infections, and excess suction in a newborn can cause a vagal response, bradycardia, right down to asystole. So RDS, also known as hyaline membrane disease, most common cause of respiratory failure in the first day of after birth, first days after birth, due to a lack of surfactant, and when the airways have a tendency to collapse, it also creates an increased negative pressure within the alveolus, and that drives fluid towards it, so they develop pulmonary edema and crackles on auscultation. And prematurity is the single most common cause. So we want to pay particular attention to the airway and PPV if that's necessary. So feedings, bottle-fed babies will take 6 to 9 feedings in 24 hours. Breastfed babies prefer feedings every 2 to 4 hours. Generally speaking, breastfed babies may go 5 to 7 days without stooling or have 6 or 7 stools per day. So now if mom told me there was unusual stooling, if there was a change is different, right, from the norm. Color of the stool, not as important as things like blood in the stool. Respiration, so normally they breathe at 30 to 60 breaths per minute, and sometimes they'll have 5 to 10 second pauses. But if any call for a neonate or an infant with apnea and cyanosis warrants transport to the hospital. Some causes of prolonged crying in kids include corneal abrasions, which may be difficult to detect, hair tourniquets, and I've got an image of that on the next slide. Stomatitis, so inflammation, ulcers of the mouth. Subdural hematomas, usually non-accidental, so this is a case of child abuse. fractures would be non-accidental. Inborn errors of metabolism, something that we have no real clear clinical signs and symptoms of that for you and me, other than some feeding changes. Sepsis, UTI, meningitis, congenital heart disease, like SVT, encephalitis secondary to herpes. That's what a hair tourniquet looks like on the toe. So, not a bad idea to look at things like the hands, the feet, the penis for hair tourniquet. Oops. So this is an SVT in a newborn, and so SVT in infants, when you see a heart rate greater than 220, that's SVT until proven otherwise. In pediatrics, it's over 180. So over a year of age, over 180. Under a year of age, over 220 would be considered SVT. So non-specific signs and symptoms: fever, hypothermia, abdominal muscle tone, limp or stiff, weak suck, poor feeding, jaundice, grunting respirations, cyanosis and mottling vomiting. This is petechiae, and of course, what's the first thing you think of when you see a child with petechiae? Meningitis. Yeah, exactly. So maybe a sign of meningitis. It's a serious finding. Any mental status changes or history of seizure with petechiae is meningitis until proven otherwise. And that basically means that you and I have to protect ourselves really well, because it's transmitted by droplet, not just bodily fluid. So we need to wear a mask, goggles, gloves, ideally a gown as well. So maybe decreased feeding, warm skin, rash, or petechiae. Sometimes neck stiffness, and the way to assess neck stiffness is to just cup your hands under the occiput and flex the neck, or lift the head and flex the neck, and if you meet resistance, then they've got neck stiffness. Vomiting and diarrhea, so rarely an isolated symptom, is considered a serious pathology in any neonate, and with significant consequences, including they dehydrate very, very rapidly. They can develop electrolyte imbalances, which can lead to dysrhythmias and other complications. Hypoglycemia, so neonates are the only age group to develop serious hypoglycemia in the absence of diabetes, and common in preemies. May indicate some serious underlying pathology. It's catastrophic for brain cells, obviously, because the brain cells use glucose without insulin, and much shorter time frame than adults. So it's got to be corrected quickly. And neonates lack glycogen stores, so they're unlikely to respond to glucagon. So under the age of 2, we're looking at blood sugars less than 3 millimoles per liter. The indications for dextrose would be agitation, altered LOA, seizure, or symptoms of stroke. And if you carry D10 pre-mixed, and hopefully we'll be doing that by next year, both for adults and for kids. If they're under 30 days, then they get 2 mLs per kilo to a max of, or 2.2 grams per kilo to a max of 5 grams. And if that doesn't work, then they can be given a second dose after 10 minutes. And if they're equal or greater than 30 days, they get the same dose, basically 0.2 grams per kilo or 2 mLs per kilo to a max of 10 grams. That's really the only difference here. And a second dose after 10 mLs PRN. If you're using a D50 solution, which is what most of us are using now, if they're under 30 days, then we dilute it to D10W. And how do you dilute D50 to D10? Yeah, and how do you get 4 to 1? Just tell me how you would go about doing that. drop 2 mLs of D50, add the simplest way is probably to dump 40 mLs out of your ampule and add 40 mLs of normal saline. That'll give you 10% solution. Does that make sense? Or what is it, 45? I'm trying to think now. Yeah, I would use the easiest method. But whatever you need to do to get D10 is fine, as long as you're getting a D10 solution. And again, the dose under 30 days would be the same. If they're between 30 days and just under 2 years of age, and using the D50 solution, then we can go to D25, so we get rid of half of the ampule and draw the rest up in normal saline, and give this again 2 mLs per kilo, or 0.5 grams per kilogram. And yeah, thanks, MJ. And then we can administer up to 2 doses, and if they're 2 years of age or older, then we go with D50. I would just push it slowly. The risk of giving a higher concentration of dextrose in the neonate, maybe not as much of a risk in a 1-year-old, but in the neonate, is that the osmolarity is very high, and that can actually cause intraventricular hemorrhage with that kind of concentration. Glucagon, so if they're under 25 kilos, they get 0.5 milligrams IM glucagon, and if they're 25 kilos or greater, then they get a milligram of glucagon IM, and that can be repeated in 20 minutes. Intestinal colic, so this should be considered when there's crying for more than 3 hours for at least 3 days per week. Seldom lasts beyond about 3 months. And non-accidental trauma or abuse should be considered when any unexplained bruising, skull fractures, palpable or suspected, extremity fractures, cigarette burns, unexplained irritability, lethargy, or coma. Fever, sepsis, so high risk of sepsis in the premature newborn. Oopsie. So that's a temperature 38 degrees or higher, and we need to take fever very seriously in the neonate. It can be life-threatening in that age group, and so they need a workup at hospital, CBC, urinalysis, blood culture, all those sorts of things that we can't do outside the hospital. Diarrhea is serious because they can become dehydrated very, very rapidly, volume depleted, hypovolemic, irritability, lethargy, poor feeding, dehydration. And we look for signs like dry mucous membrane, sunken eyes, sunken fontanelles, and so on. GI symptoms. So they may have some non-specific signs, and let's talk about some surgical candidates. So irritability, inconsolable crying, poor feeding, vomiting, not the same as regurgitation, so vomiting is unusual, particularly in the neonate. And bilious vomiting would be considered serious, potentially life-threatening, and that would be like a Shrek-colored vomiting. Constipation would be another problem. Abdominal distension. Other GI symptoms, feeding difficulties, and so we rely heavily on the parent's perception. Signs of malnourishment, or parents report no weight gain or excessive weight loss. Dehydration. Some causes include simple infections, esophageal stenosis, esophageal stricture, laryngeal clefts, so it's a congenital opening between the posterior trachea and the anterior esophagus, and that can lead to stridor, cyanosis, aspiration of gastric content. And again, history of poor feeding since birth. So regurgitation is spit up, and that's due to a lower esophageal sphincter pressure and a relative increase in intragastric pressure in neonates. Typically self-limiting. If weight gain's been normal, then can surgeon focus on their hydration status. Vomiting, on the other hand, is forced contraction of the diaphragm and abdominal muscles, and it's considered very serious in the neonatal age. Causes include increased ICP due to shaken baby syndrome, urinary tract infections, sepsis, hepatobiliary disease, usually with jaundice, inborn errors of metabolism be another cause, and a bilious vomit would be a surgical candidate proven otherwise. Other symptoms. So lots of causes of diarrhea, but we want to be alert for dehydration, hypovolemia, pallor, altered LOC, blood in the stool. Constipation, so breastfed neonates may go a week without a bowel movement. And if they've never passed the stool, the differential for that would include intestinal stenosis, intestinal atresia, which is an obstruction of the GI, usually at the ileum, meconium ileus or plug, so an ileus is an impairment in peristalsis, or Hirschsprung's disease, which is the nerve cells are missing in the last part of the large intestine that cause the intestine to contract, and without that, stool accumulates. Anal stenosis. So questions to ask, after ABCs, ask questions about, what do you make concerns about the baby? Tell me what's going on with your baby. Get a history of presenting illness. Has there been a fever? Has it been treated? Any seizure activity? Any unusual crying? Or what's the child's activity level? Has that changed recently? Has the child been vomiting or just regurgitation, which is what we expect? What's the food and liquid intake been like? And has there been a change in the number of diaper changes? So in terms of the HPI, we want to know, when this started, what they've been doing at the time, were they awoken from sleep, how long have they been ill, crying, or feverish, and have they been to the doctor? Is there a diagnosis? Was there treatment prescribed? Has that treatment been initiated? Has there been a fever? And what's their fever been? Oftentimes they give us temperatures in Fahrenheit, and you've got to do the math conversion, so it's good to have an app for that. Excuse me. And so what has their temperature been? How long have they had it? And how are you treating it? What medication, what dose? And has the baby had any seizure activity? And if so, how long did it last? Did they fall as a result of the seizure, or all limbs involved? And if not, what kind of focal seizure we're looking at? And then, of course, we look for any child with an altered LC or history of seizure or postictal. We're going to look for neck stiffness and a rash or potential meningitis. So, crying, the usual just information. When did it start? How long has it been going on for? How often does the baby go through this? And is it crying from different? Do they become cyanosed when they cry? Because they may not think to tell you that. And of course, you can also take the chest during crying. Want to know if the child seems more irritable than normal or more tired than normal, any altered LOC, and are they making appropriate connections with their mom or their dad, and what are their sleeping patterns like? We already talked about this, and how many times did they vomit or had diarrhea in the last 24 hours? That's relevant information. And what's the color been like? Has there been any blood? Has it been watery or solid stools? Any unusual smells? Anything about projectile vomiting or projectile diarrhea? And do the parents suspect any aspiration or poisoning? Would also be relevant. So food intake, has that changed? Have they been eating normally, or have they been showing any sort of loss of appetite? Any problems with breastfeeding? And breastfeeding problems are fairly common. I know my wife had to go to the breastfeeding clinic for about 2 weeks solid until my daughter finally started to latch on a regular basis. That's probably TMI for you guys, but bradycardia is most commonly caused by hypoxia, and so we treat with oxygenation plus or minus ppb, and we want to resist the temptation to treat bradycardia pharmacologically. But if they don't respond to ppb, consider patching to a base hospital doc, see what they want you to do. Hypovolemia is by far the leading cause of shock in newborns, and hypovolemia not secondary to trauma, but typically secondary to fluid loss from vomiting and diarrhea from illness, right? So they may appear pale and cool, diminished peripheral pulses, delayed cap refill, mental status changes, sunken eyes, fontanelles, diminished urination. Those are all signs of dehydration, and fluid resuscitation is done as per directives. The only caveat here is that if you're doing fluid resuscitation, you should be using in an infant, you should be using either butyral or a syringe to push fluids, so you're a little bit more precise about the fluids. So a saline lock and a 60 cc syringe, or even a 10 cc syringe, with 10 cc's at a time, is probably just fine. And make sure you auscultate chest sounds. You're not putting them into failure. So seizures are considered very serious. They oftentimes present much more subtle in infants. Rather than full-out tonic-clonic seizures, we often see just tremor-like activity. And we want to find out if they're focal or multifocal. If they're focal, that might suggest a lesion of some sort. They may be myoclonic, so there's brief, rapid, jerk-like movements. And in terms of resuscitation issues, so cardiac arrest is almost always the result of hypoxia, so ventilation, oxygenation are your highest priorities when it comes to neonatal resuscitation and infant resuscitation. Risk factors include bradycardia, intrauterine asphyxia, prematurity or maternal drug use, congenital diseases, intrapartum hypoxemia. So care is largely supportive that we provide. So get a history, head-to-toe exam, glucometry, SpO2, O2, temperature, ECG, IV PRN. Does anyone know what the typical weight criteria is for pediatric defib pads as opposed to adult defib pads? And by the way, there's no reason why you can't use adult electrodes if you can't find the pediatric electrodes. So just kind of big and bulky. I see some people typing an answer here. Just waiting on those.
One thing to keep in mind, and I'm curious how it'll work with us, but I know that the defib pads, the pediatric defib pads that exist, have an attenuator built into them. So if we were to take these pads, plug them into ours, if they were compatible, in theory, they would be getting potentially less electricity than we would be providing through ours. That's fair to say?
Yeah, I think if you're lucky to have energy attenuating pads, that's great. Alternatively, use PED pads. And but I see 30 days to 8 years, but PED pads are generally used for infants under 15 kilos. Yeah, thanks, Terry. Yeah, so 0 to 15 kilograms typically. So we're typically talking less than a year of age. All right, but if you use adult pads, it's probably not a big issue as long as you choose the appropriate joule setting or you've got energy attenuating pads. That's really key.
Provided you don't touch the electrode, would cutting it compromise the integrity of the pad if you had to?
Oh, that's a good. Yeah, that's a good question. I would say probably not, but I don't think anyone in your service or the manufacturer would want you doing that. So, so I would just not do it if you can. And just get a set
Okay.
of PET electrodes instead. Yeah. Any questions about this? Because I want to do some review with you guys. I see Andrew's typing. So. Oh, you've got a set of expired P pads with you. Because every off-duty paramedic should have a pair of expired P pads with him or her. That's awesome.